Hi all, and a very good afternoon. Welcome to another SJMC Grand Round, streaming live to you from Facebook and YouTube. I'm Anson from SJMC, and I will be the presentation coordinator for today. Before I introduce the panelists to you, for those who are watching from Facebook, please like and subscribe to the channel to receive notifications on the latest content. Allow me to go through the housekeeping slides with you, doctors. This is the 14th SJMC Grand Round. As usual, we would like you to ask questions using Slido. Please join us on slido.com, and the code is 601511. You can also use your normal QR code scanner in your mobile, not the one in MMA app, to scan the display Slido QR code. It will direct you to the Slido website. Kindly key in your name as per your form registration. This will allow us to trace the details and to deliver the mystery gift to 5 winners. Kindly ask our panelist questions in Slido. Towards the end of the session, we will display the QR code for TPD points collection. Do use your MMA app to scan the QR code. Tap on the scan, circle in red as per display visual, and scan the MMR code. Kindly allow me to introduce Dr. Paul, consultant cardiologist, to you. He will be the moderator for today. Thanks, and over to you, Dr. Paul.
Thank you very much, Anson. A very good day to everyone, all of our audience here. Today we have our 14th round of SJMC Cardiology Grand Round. And as the team proposed today is the ECG Fun Quiz. So just focus on the fun part, all right? So now we're going to, the last time, if you remember, we have also ECG session. That was a bit more spicier at the jalapenos pepper level. I think we have to downgrade a bit. So we go to ECG that we probably often see in our clinic and clinical practice. I hope you can learn a lot from our expert panelists today. We're going to present the cases as the ECG level. So we have about 10 ECGs, and let's do it the fun way. Register your Slido. Please register with your real name, because you might have, the winners will receive prizes, I think. Anson, right? Correct?
Yes, you're right, doctor.
So please use your real name, and we have 4 consultant cardiologists from SJMC, Dr. Choi Chun Mok, Dr. Shamrose Khan, Datuk Dr. Yap Lok Bin, and Dr. Navin Sukilan. So we're going to start off with a bit of introduction of today's ECG's topic, which, hold on. Okay, now we're going to talk about localization of myocardial injury. Basically, talk about acute coronary syndrome. Patient come in with a chest pain and you do ECG. What do you look for, especially for if you suspect having an acute coronary syndrome? Now, what are considered as significant ECG changes in a patient with a chest pain or suspected acute coronary syndrome? Now, you can see the first one will be ST elevation. So any combination of ST elevation in 2 contiguous lead and ST depression, we call it the reciprocal ST depression. 2 contiguous lead. This is very high likelihood patient has a problem. Now, if you just have a ST depression greater than half a box alone or concomitant with T inversion, then also likelihood if the patient having a chest pain with a risk factor. Now, if you just have a ST elevation only without reciprocal changes, it still can be a acute coronary syndrome, but then you have to base on history and look at the patient again. And the isolated T inversion is probably a bit non-specific, like the third ECG here, but still can consider significant if the whole clinical scenario fits the diagnosis of acute coronary syndrome. One thing that you have to remember, that in the case of any artery occlusion in the heart, there's always there's evolving changes, we call it, meaning that it depends on which hour or which time did you caught the ECG. If you caught it in a very early phase, sometimes the ECG may be normal. And if you catch it at B, then the ECG may appear to be like non-diagnostic, non-specific. But then if you repeat it later on, 15 minutes later or 30 minutes later, you can see that the changes is dynamic. Okay, this is called a progressive ECG changes and usually signify a acute event. So this is very important. So the key message is if the first ECG doesn't show anything, it doesn't rule out a problem. And your diagnosis, if you think is acute coronary syndrome, you have to repeat the ECG in maybe 10 or 15 minutes time. Now, then when you look at the ST elevation, ST depression, then you ask ourselves why we need to localize the ECG. Maybe let us ask the expert panelists here. We start with Shamruz. Why do you think that we need to localize the ECG changes?
Hi, cool. Thanks everyone for joining us again today. Basically, based on the ECG changes, you can actually estimate which arteries are involved, especially in acute ST elevation MI. When you go in, you want to know which artery to intervene because some of these patients may have multi-vessel disease. Some of these plaques may be stable, but what you want to intervene is the unstable plaque. So the ECG localization sometimes can be very helpful so that when you go in, you can just focus on the arteries involved in the acute STEMI setting.
Good. Naveen, any opinion why we cardiologists like to localize the ECG?
Yeah, I mean, I agree with what Shamru said. That's basically the most important part. Another thing also, when I go in, I'm mentally more prepared. I know which is the one that I need to intervene. Sometimes the equipment that we use for the right and the left can be different. So we can, if we know that the right side is the culprit, then we probably just take diagnostic shots using a diagnostic catheter on the left, and we go with our guiding catheter, which we require for intervention straight to the right side. So it helps the thought process before you go in for acute case as well.
Dr. Choi, any other thoughts?
Yeah, so in addition to whatever has been mentioned, from the management point of view, I think there's also some extra benefit. It makes a big difference if you have a patient with inferior MI, because we do know that sometimes they can develop bradycardia, AV block, what to do when you have this kind of a complication. You can give atropine, does this patient need pacing? And also, if you have an extensive anterior MI, sometimes you are worried about cardiogenic shock. So running fluids in them might be a bit challenging as well. So I would say, from the treatment point of view and the prognosis part, localization is also equally important.
Yep. Dr. Yap, any other thoughts?
Yeah, so I would go back a bit, if possible, to look at the value of looking at ECGs, particularly in ST or T wave segments, because we are focusing today on myocardial infarction, but when we see a patient with chest pain, I think before we even diagnose an MI, there are other possibilities. For example, we often see changes such as ST depression or deep T wave inversions in LVH, left ventricular hypertrophy. We may also see very widespread T wave changes in conditions such as pericarditis or myocarditis. Now myocarditis is very, very topical. So to actually locate distribution, to know which leads are the common ones that are affected in MI is quite helpful, because I may see T wave changes widespread, in which case I think maybe it's not an MI, as opposed to T wave changes in certain leads like the anterior leads or inferior leads. So I think the locality of these changes is also very important in the first place to differentiate between acute coronary syndromes versus other kinds of conditions that can cause chest pain.
Well, that's an excellent point. Yeah. So very good points. All the panelists that have been given. I think number one, probably diagnostic. You want to know whether it's really an MI or not MI. Something like what you have said, pericarditis, myocarditis. So these are not localized; they are global. So those who are localized are usually the changes at the artery distribution. So number two is prognosis lah. Like a massive anterior MI, you know that the patient going to be poor prognosis. You gotta get ready. Patient may get into complete heart block, hypotension. Patient with a RCA, infarct, inferior MI, also you have to be careful because when you go in, sometimes it goes into bradycardia. So good. Now, in a primary care setting, if you have a patient that you suspect non-ST elevation ACS from we have a new guideline now from the National Heart edition 2021, and you can actually start the aspirin 300 non-entry coated in your clinic, and you can serve a sublingual GTM if you the patient blood pressure is stable generally, and you can start calling your ambulance, and while waiting for the ambulance, help to set up the intravenous access as possible. And as Troy mentioned, sometimes we need to be anticipating problems like massive anterior MI. You know that patient going to go into hypotensive cardiogenic shock. So you help us to set the IV line early. If not, when the BP drop, it's very difficult to get an IV line. And of course, inform the hospital prior to transfer, preferably. So we will wait for the patient and activate the CAT labs sometimes earlier before the patient arrives. Okay, now, if you look at the heart, we have 12 lead ECG. Generally, the anterior lead, let me show you my laser pointer, if you can see. Okay, now, these are the precordial lead, V1, V2, V3, V4, V5. These are the ones that going to look at the anterior portion of the heart. Yeah, you can see the heart here, anterior portion of the heart. Now, lead 2, 3, and AVF are going to look at the inferior portion of the heart. And lead AVL, lead 1 will be looking at the lateral portion of the heart, right? The lateral portion. So, to make it simple, if you see ST changes localized at V1, V2, most likely we are dealing with a septal, anteroseptal injury, all right? And the anterior wall is larger, so you involve lead V and 3, and sometimes V2, V3, V4, V5. Lateral wall involve lead V5, V6, 1, and AVL. All right. Now imagine you have an artery that is blocked at the anterior portion of the proximal left anterior descending artery. Then you will block the diagonal artery as well, and the ECG will be the combination of anterior and lateral. So you have all these V1, V2, V3, V4, V5. Means that the more lead you see is elevated, the more extensive the anterior wall is. And the remaining leads, mainly the lead 2, 3 AVA, you will see something called a reciprocal changes, like a mirror image, ST depression over there. Later, we will see it again in the cases that our panelists will show. So this is the inferior wall, looking at lead 2, 3, and AVF. If there's any changes there, you will suspect inferior wall. And look at this heart model. The inferior wall is somewhere below the diaphragm. Often patients comes in with the epigastric pain. Now, if you think that the epigastric pain is a bit unusual, like your normal gastric pain, especially patient having exertional like gastric pain, patient with a multiple risk factor, diabetes, hypertension, smoker. Sometimes this kind of gastric pain can be misdiagnosed as gastritis, but actually is an inferior myocardial infarction. So you might want to do an ECG, and that's where you practice your localization skill, looking at the inferior lead, whether there's any subtle ST changes or ST depression or not. All right, without further ado, are you all ready? Have you all download the Slidos, and we shall be ready for the ECG quiz. I'm seeing not many people registered yet. Maybe we wait for a while.
Yeah, I think we should wait for them to register first. Otherwise, not enough.
So as you can see on the screen, there's you can either use a QR code to log into the Slido. Got prize, Anson, so maybe I should try myself as well. Let me check.
Surprise, doctor. Mystery prize. Do join us, doctors, for the Slido question session.
Right, I'm in. Okay, maybe we can start without wasting time. I think they can join in later, but of course they will not get the highest mark lah. Okay, round one. I think start with Dr. Choi. Anson, maybe you don't show the answer first. Show the slide first. Anson, can you show me the slide again? Not the Slido slide, my slide, the PowerPoint.
Oh, okay, you do.
All right. Anson, I think when after Dr. Choi read the question only, you start the timer.
Okay, will do, doctor.
All right, Dr. Choi, the quiz is yours.
Okay, thanks, Dr. Ko. So good afternoon, everyone. I'll start the ball rolling. We have a series of ECGs to show you all. Disclosure, at least on my side, all of the ECGs are from real patients with real cardiac events. And for the first ECG, we have this 55-year-old female with risk factors, diabetes and hypertension. She came in with chest pain, 3 hours, and presented to the ER with this ECG. So I'm not gonna describe too much on the ECG yet. Technically, there are a couple of options like what you have heard from Dr. Ko, anterior septal MI, A, B, isolated lateral MI, C, inferior MI, D, isolated posterior MI, and E, the far more worse prognosis, which is the extensive anterior lateral MI. So we have a look
Anson,
at
you can start the timer now.
and we
Okay,
can
let us vote.
vote on Slido which you think the diagnosis is.
All right, we have 10 seconds more.
Choose the best answer.
Okay, great. So, Dr. Choi.
Okay, so looks like a good mix. Of course, most of your answered anterior septal myocardial infarction. I think I'll probably say the answer out first, right? So that's the correct answer. So it's actually A, anterior septal myocardial infarction. Some of you also put in lateral MI, inferior MI, and some also chose extensive anterior lateral MI. And then can we look at the ECG back again? So when you look at this ECG, as Dr. Ko has put his cursor there clearly, you can see obviously V2 is actually showing ST elevation with a very high takeoff kind of tented T waves. And this is usually indicative of anterior. And remember Dr. Ko's slide, some of the septal branches may be involved as well. So it's an anterior septal MI. Commonly, when you see other patients who are not having chest pain, young patients, they also have this kind of ST elevation looking ECGs when they come to you for screening. And of course, if we start diagnosing them as anterior septal MI, it can be quite alarming because they are actually normal, benign, so-called early repolarization kind of ECG. But if you remember our localization slides, if you that there's some kind of ST elevation. So you look at the reciprocal leads which in this case will be the lead 2, lead 3, and AVF. You can clearly see the ST depression. So I would like to add a bit on Dr. Koh's heart model image. So a lot of people think that the heart is located. I mean, it's positioned in such a way because we always say heart is like this, right? So it's not really in an upright position. The heart actually sleeps at the base of the heart. So if you look at it, that's why the inferior surface is over here, and this is the anterior surface. So when you have an anterior MI, which is the injury current going on anteriorly, usually you will see the reciprocal changes over the inferior leads. It's like looking through the window, right? So in this case, 2-3 AVF shows very clear ST depression, and that's the reciprocal change. Therefore, the answer is anterior septal MI. Why is it not isolated lateral MI? Because of the anterior septal involvement, and lead AVL and lead 1 is not markedly elevated. Why is it not extensive anterior lateral MI? Because in this particular ECG, it's just the anterior septal involvement as well. So if we go to the next slide, Anson, just to show them the angiogram. So this is the actual angiogram of the patient. If you look at Dr. Koh's cursor, and also the arrow key, this is actually the LED, the left anterior descending artery. It is occluded, or at least subtotal occlusion, and that is why the ECG behaves in such a way. And the next slide, Anson. So the usual primary PCI that we do here is actually to establish flow, so that the myocardial perfusion is restored as soon as possible to minimize complication and heart failure in the future. Any else want to add on this question from the panelists?
So, very interesting case. So, in fact, the artery was occluded actually quite proximal. So, I guess if you leave it for a while, then the whole diagnosis will change from anterior septal MI to extensive anterior lateral MI.
Yes, I agree. That's why I put there chest pain 3 hours. So, like what Dr. Koh said, is about when you catch the ECG. If we wait for it to evolve a bit longer, then you will see different ECG changes. It's just like incredible Hulk, before Bruce Banner turns into the Hulk, right? So it depends on when you actually meet him.
Okay, can we move to the next question?
Okay, so thank you. So question 2, 40-year-old male smoker as a risk factor, also hypertensive. So this gentleman came in with a chest pain for 2 hours. Again, it's a very acute kind of presentation. I mean, thankfully at SJMC, we get patients coming to us very early, probably because of the trust they have in us. So anyway, coming back to the ECG, what would be the diagnosis? A, anterior septal MI, B, Welland syndrome, C, inferior MI, D, isolated posterior MI, E, extensive anterior lateral MI. Have a look at the ECG for a couple of seconds. At the same time, I think the Slido can post up the options.
Activate the Slido, Anson.
Do we need to stay on the ECG a bit longer for them?
Yeah. So it looks like it's easier if you have the two devices. One is the phone for your ECG, and then one is a laptop or iPad to look at the ECG. Anson, can you show the ECG? Show back my slide.
So basically look at the ST segment. Is it elevated, or is it depressed, or is it absent, shortened, prolonged?
Okay, the polling closed. Let's look at the... Oh, interesting.
Okay. Wow.
So you want to explain?
Tie. Okay, so we have a tie between Welland syndrome and inferior MI. So I'll leave the Welland syndrome out. I can tell you this is not the answer because there will be further discussion on this topic later on. So it's between inferior MI and of course isolated posterior MI. Can we go back to the ECG for our Anson? All right, so if you look at this ECG, if I may say, there is no obvious ST elevation, okay? And most you can argue probably a bit of upsloping over lead 1 and AVL, but that's about it. But we don't see those typical ST elevation kind of ECG. But that's not the end of the story. Like we mentioned to you all earlier, if you can't see ST elevation, you look for ST depression. And in this case, if you look at lead V1 and V2 and V3, and in fact, even up to V4, you can see ST depression. And these are horizontal looking ST depression. So let's look back at our heart model. So when we put V1, V2, V3, V4, V5, V6, so V1, V2, and V3 will be technically looking onto the anterior surface of the heart. So if we look at the reciprocal part of the heart, will actually be the posterior surface. So whatever is depressed on the anterior wall should appear elevated on the posterior wall. So hypothetically speaking, if I were to put, the posterior leads for this patient, I should be seeing ST elevation. So it means that the posterior wall is actually getting a lot of ischemic current injury. So this patient actually has a posterior myocardial infarction. Now, I don't think there's such a thing called only posterior or only inferior. So this patient, because of the posterior involvement, a lot of times it also involves the lateral wall, because that's how the artery supply is. So if you look carefully at lead 1 and AVL, you can actually see a subtle ST elevation, which probably points towards lateral wall injury as well. So this patient, if you were to revise it in your mind, probably has ST elevation over the posterior leads and also a little bit of ST elevation over lead 1 and AV. Okay, some may even argue lead 1, 2, and AVF also has a little bit of ST depression, which again is a reciprocal change towards the lateral ischemia in this particular patient. So I would like to show you the angiogram, which is actually the next slide. How do I know? Because I did the angiogram. So anyway, so not because my ECG is so good. So you look at the arrow. So it shows that this is the circumflex. The circumflex artery is totally occluded. All right. So circumflex actually goes around the heart. Okay, it supplies the lateral wall of the heart. And in this particular patient, it also wraps all the way to the back. It also supplies the posterior lateral part of the heart. That's why the posterior surface is involved in him. So for those who are not familiar with the angiogram, circumflex is usually not this short. Okay, so it is occluded on this slide. And Anson, if you can show us the post-revascularization slide, you can see how big it actually is. So it goes down and it goes to the lateral wall and also the posterior wall. So that's why this patient, if you look back at the ECG, has ST depression over the anterior leads. So I guess the thing to learn from this ECG is that sometimes when you don't see an ST elevation in a patient who comes to you sweaty, feeling very uncomfortable, telling you that I got chest discomfort, who also has high risk factors at the same time, please don't brush him off. Please don't say, oh, this is anxiety, take some Xanax and come back the next day. Look really hard for ST depression. You can't see elevation. And in this case, his depression is actually ST elevation over the posterior wall. So anyone want to add?
I mean, hi, Chai. Just very interesting. I mean, back in hospital setting, usually we even ask them to do the posterior leads, like you mentioned, So maybe you can just explain, like, to the GPs how we usually do that. The first 3 leads, I'll just briefly say that the first 3 leads, usually you can move it to the posterior aspect, and then you can see the ST elevations in V7, V8, V9. Or the other thing we used to, talk about is just flipping the ECG over, and then you can actually see that in V1, V2, V3, you can actually see that it's a ST elevation in those leads. So that's another trick to it.
So remember that the reciprocal change just basically just a mirror image of the ST elevation, because we're seeing through the infarcted wall. So like what Dr. Nabi mentioned, just flip it around. So whatever depressed becomes elevated, and usually it's a good way to evaluate the ST elevation.
I mean, if you're not sure if you see any ST depression or ST elevation with this kind of symptom, just refer them.
Yep. So
To
that's why
SJMC.
in the earlier slides I mentioned the diagnostic, if you have at least 2 contiguous leads, a bit of ST elevation, and 2 plus 2 contiguous leads, a bit of ST depression, that's already very high probability you have acute coronary syndrome.
Correct, especially if the patient has a high risk coming in with typical symptoms. I think because ST elevation is carries a bigger kind of so-called morbidity compared to a non-elevated ST segment ECS. So
Great.
okay,
We will move forward. Question 3 again, Choi.
Okay, this is my last ECG. Very interesting ECG because I think it kind of like triggers off a lot of discussion. So this patient, again, gentleman, very young gentleman. This is a true story. I think just last month, in fact. Very young gentleman, a nice day, I think about 2 o'clock in the afternoon, came over with chest pain. So he didn't want to come initially, but finally the wife said, "You don't come." Okay, anyway, so he came. So he's, other than being dyslipidemic, he has no other risk factors. Non-smoker, he's non-diabetic, he didn't have any hypertension. So he came very acutely. So he lived nearby USJ. So 1 hour we arrived to ER, and our ER is very, very efficient. Within minutes they got the ECG up, and the moment they saw the ECG, they called me because I was on call. They called me and I saw the ECG. Then I technically activated the cath lab. So before we discuss about the ECG, let's go through the options here first. Again, it's the same options: anterior septal, Welland syndrome, inferior MI, isolated posterior, extensive anterior lateral MI. Maybe the participants can vote first, and then we can have a bit of discussion. Maybe Anson, you can keep the ECG. I think.
Sorry?
Or we need to put the ECGs up a bit longer.
I think it's a bit too late now. Okay.
Whoa. Wow, after 3 slides, I think try to make educate all the audience out there. They got mostly correct now.
Yeah, at least the anterior part, I think very prompt diagnosis after this. Okay, so how much was 48%? I can remember. So anyway, majority of them voted 83% voted extensive anterior lateral MI, followed by anterior septal MI. Good. I guess this is the perfect kind of combination of results. Let's go back to the ECG again. So the answer is extensive anterior lateral MI. Although 18% of you voted anterior septal, let's go through, and the rest can fill me in if there's any other points you might left out. So this is an anterior MI for sure, because there's ST elevation, V2, V3, V4, and if you have attended lectures and read certain books, they used to call this some kind of tombstone sign, right? Right. So because it does look like tombstone, and secondly, some of these patients are nearer to the tombstone than what they think. There's anterior involvement, and if you look carefully, the ST elevation also extends all the way up to V5, and some may even argue V6. And now, when you think of lateral involvement, then your eyes switch to V1, V1, and also AVL, which also covers the lateral wall. So in fact, there's ST elevation everywhere, from V2 all the way to the lateral wall. So therefore, the anterior wall, septal wall, and the lateral wall is an extensive anterior lateral ST elevation. Okay,
Sorry.
remember? Yep, sorry.
Based on this ECG, do you think you can estimate the location of the blockage?
Oh yes, that's a very good question, Shamrus. So as I was showing this thing, so before I answer Dr. Shamrus' question, which is very relevant in this ECG, so the involvement is anterior, septal, and also lateral. So the whole area of this heart is involved, except the opposite wall, which is actually the inferior wall. That is why lead 2, lead 3, and AVF seem to have depression, which again shows the opposite of whatever is going on the other side. So Dr. Sharma's question was, where do you think the infarcted segment is, which is very important for us who are going in to do a PCI, because we can anticipate whatever is going on in the cath lab later, right? So I would predict that the occlusion has to be very, very, very proximal. We talk about the whole LED. It shouldn't be the distal part of the LED itself, which usually don't cause death. It should be somewhere all the way to the proximal. And of course, sometimes in worst case scenario, it may be some kind of left main equivalent as well. All right, so I would say it's a very proximal part of the LED. Dr. Shamus, you want to add in something?
Yeah, I
Your own
agree.
experience?
I would certainly think it's before the diagonal branch.
All right, because the diagonal supplies the lateral wall, so therefore
Yes.
it has to be as proximal as before the diagonal branch as well. So of course, in this case, let's say his BP is low. How many would actually go in with some kind of pressure support, like inotropic support, or maybe even balloon support? I would say it is quite important. Right? If they say the BP is low, we have to anticipate, because if the lesion is very proximal, sometimes while doing the case, the patient might just crash, right? So I think it's also important to localize the segment in that case. Okay, so let's look at the angio. Maybe the next slide, Anson. Okay. So I purposely chose this angle because this is the angle where you actually can't see the LED. So the whole LED is not seen. So it's not the distal part, it's not the mid, it's not the proximal. Sorry, you just go back, Anson. Back one slide. Yeah, it's actually the whole LED. So those tiny small ones, those are not the LEDs, those are the branches. So the length, the whole length of LED is actually gone. So it's occluded. Therefore, it explains the extensive involvement of the MI. So if you look at the arrow key, you just remember that position. Anson, you can go to the next slide. So this is after prompt revascularization. So this is the real and actual LED. Okay. To add on, So to add on, this patient actually developed hypotension, and we have to resuscitate him, but he's actually well now. So he's excessive anterolateral MI. Anybody else would like to add?
Hi. Yeah, earlier we discussed about the importance of the ECG and localization. So for example, like in a case like this, because you can see that he also has a tight stenosis at his circumflex and obtuse marginal. So we know, based on the localization from the ECG, that the culprit artery is the LAD, and so that's the one that correctly you actually intervened. And when he's more stable, you can bring him in later to do the other vessel.
Yeah, correct. So although however tempted we are actually to treat the non-culprit sometimes, because this young chap
patient is
actually
unstable,
APO unstable. Yeah, no choice but to stop. And I just fixed the cert the other day. He's well now actually.
How was his LV function, Choi? His echo?
It was intact when he came in. It was about 40% with the anteroseptal lateral involvement, but the last echo I think about 50 to 55.
Because I think he presented very early, within 1 hour. So that's the importance of picking up these patients early, because we've had patients who come in after 4 hours, 6 hours, and they don't fare as well. They may survive the index procedure, but later on they develop heart failure. It just complicates matters.
Correct.
Can I just add one point? Are we able to go back to the ECG just for a short while, just to talk about Ecg criteria? So I think throughout our learning and teaching over the years on MIs, one quite important thing is how many millimeter ST elevation is there, and what is the criteria that will make us confirm that there is MI, in this case, anterior MI. So classically, we are taught that certainly for chest leads, in this case, anterior MI, there should be 2 millimeters, which is 2 small squares. I know this on this slide is a bit hard to see the 2 small squares, but the one big square will be 5 divided into 5, and you will see the very small square in each of the 1 millimeter basically. So in here, I think you were pointing at V2. Probably we see about 2 or 3 millimeter ST elevation. So the classical criteria to be met, you need 2 millimeters in 2 consecutive leads, or contiguous leads. So in here you can see V2, V3 have at least 2 millimeters. And now we often also get patients with high takeoff, and even in our health screening, sometimes we will see people with no chest pain, they have ST elevation described on the ECG. So I think this criteria where you clearly have 2 millimeter is probably quite helpful. Sometimes even high takeoff can also have quite a lot of, ST elevation. But again, we come back to reciprocal change. When you have high takeoff, you probably do not anticipate reciprocal changes here, as you can see in the lead 3 and the lead AVF. So the reason why I wanted to touch on the criteria is because in an anterior MI, you have 2 consecutive leads of 2 millimeters, but it's different for inferior MI. I think we can move on. Yeah.
Okay, sure. So thank you very much. I think Choi, maybe we answer some of the relevant questions rather than leave it to the end. Choi, how about, let's say, if you are, would you advise our family physician doctor when they see this ECG, load some aspirin, and then Dr. Kashyap was asking, how about adding Plavix 300 milligram in addition to aspirin in the clinic setting itself?
Yeah, that's a very good question. I think, in my opinion, preloading the patient with a 300 milligram of clopidogrel will be very helpful in terms of achieving reperfusion later on when the patient comes over, and of course for the PTCA as well. So the short answer is yes. I think it would be definitely helpful in a case like this, especially this anterior lateral MI.
All right, good. And Dr. Yu asks, how do we not miss the posterior MI in primary care since the ECG changes are not so abnormal?
Okay, so I guess all right, so for posterior MI, I purposely chose this ECG because it's a real case. Because sometimes, because we are too engrossed with the ST elevation, that we tend to forget about the ST depression. This patient is very hard to miss because he came in, he looks very unwell. He looks unwell, he's tachycardic. Heart rate was about 100 when he came in initially. He was really in pain, all right? And he has risk factor, smoking and hypertension. That is why we have to sit down and look closely at the ECG. And in this particular case, when you see this kind of ST depression, which we don't see in the normal benign ECG, you have to consider acute coronary syndrome. And like what Dr. Nabi mentioned, you are not too sure, either you flip the ECG around or you put more leads to the back and check for the posterior leads. And if you do see the ST elevation, I don't think the diagnosis will be missed. What do you think? Anything else to add?
Another thing is more practical. Remember, we say it's evolving changes, so you just need to repeat another ECG maybe 10 to 15 minutes time. Sometimes you might see the ST elevation in lead 1 and AVL is more pronounced. So that's a very important thing. Okay, let's go to question 4. Dr. Yap, please, your case.
Okay, this is the ECG of a 48-year-old man with epigastric pain. He thought it was gastric, but he had persistent chest pain. Came to ER. The history is basically he's a smoker and he has a strong family history with his father. So let's focus on the ECG. And what is the diagnosis? I think you can answer on the Slido. A, anterior septal MI, Welland syndrome. B, C, inferior MI. D, isolated posterior MI, or E, extensive anterolateral MI. So let's maybe just give the audience 1 minute just to have a quick look. Have we got the answer yet?
Anson, you can on the polling, but can you rename the slides so that people can have a look?
Okay, yeah,
Okay,
question
will
4.
do.
Please answer from the ECG. Okay, that's question 4, yeah.
All right, time's up. So most of them think is inferior myocardial infarction.
Yeah, which is correct. So can we go back to the ECG and talk a little bit about ECG, please? So well done. So in this ECG, the most obvious finding is that if you look at the inferior leads here, which is on the left here, 2, 3, and AVF. Can we point? 2, 3, and AVF. Are you able to highlight the 2, 3, and AVF?
Yeah.
Yeah. So leads 2, 3, and AVF, if you look from the isoelectric line, there's ST elevation, especially obvious in lead 3. There is probably about 2 to 3 millimeters. So for inferior MI, if you have 1 millimeter of ST elevation on 2 consecutive of these leads, then it satisfies the criteria. Just a very quick mention, reciprocal changes are usually in either lead 1 or AVL and V5 and V6. Okay, so this is quite simple, I think. Since most people got it right, can we show the angiogram? So inferior MI typically corresponds to the right coronary artery. So this is the RCA, where you can see a very tight stenosis. Sometimes it's 100%. In this case, it's probably about 99%. And the occlusion basically caused the changes on the ECG. Can we go on to the next slide? And basically, this was stented successfully and the patient recovered. So I think we can move on to the next question.
All right.
Okay, this is an ECG of a 40-year-old man. Now very, very common after AZ vaccine. After any vaccine, people get chest pain, they come and they get assessed. So this is his ECG. Of course, in this case, despite the history of the vaccine, his troponin, we already know is already mildly positive. So the ECG is quite subtle. Please look at the ECG and see whether you think it's A, B, C, D, or E.
Anson can start polling while remain the ECG slide here.
Do we have the answers yet?
10 seconds. We'll be closing.
Okay, great. I'm surprised everyone did so well. Can we come back to the ECG? The answer is Welland syndrome, B. Now, what is Welland syndrome? First of all, Welland syndrome is ECG changes that is consistent with LAD lesion, which is critical stenosis. Okay, for example, if you have a 99% stenosis on your LAD, you may get some changes in the anterior leads, but they are not STEMI changes. So if you look on this ECG at V2 and V3, a little bit in V4, you will see that there's a bit of ST elevation and a bit of T wave inversion. So this is called biphasic T wave. Okay, this is a typical change on the ECG of Welland syndrome. Who is Welland? Welland is a Dutch cardiologist. I show you his picture here, which I looked up. He's a famous electrophysiologist who described this syndrome about 60 years ago. Okay, so now we still use this term for critical LAD stenosis. Can we see the angiogram? So over here, you can see the LAD, and the red arrow is pointing towards a very tight proximal LAD lesion. And can we see the next slide? So after PCI, the stent is inserted into the proximal towards the mid vessel, and the problem is resolved. Okay, so that is Welland syndrome. I think we can move on to the next question.
All right, now is round 2. I think everybody have warm up already. Now we have to go lightning fast. We call it rapid fire session. All right, so we will let Dr. Shamruz and Dr. Naveen to show the cases. And please, on your phone Slido, we're going to be fast now and see who will get the top 5. All right, let's go. Naveen.
All right. Okay. So our patient's a 55-year-old man, known case of dyslipidemia, ex-smoker with sudden onset of chest pain and also shortness of breath and sweating 1 hour after cycling. So like all our previous patients, they all present very early, and this man presented within 1 hour after onset of his symptoms. All right. So that is the ECG here. So what is the diagnosis? Acute anterolateral ST elevation MI, inferior ST depression, acute posterior ST elevation MI, or is it a non-STEMI? So
Answer,
please
Pauline.
look at ECGs and
Can we have the polling, Anson?
Yeah, hold on. Let me project some technical errors. Let me project it again.
okay, do we have the results yet?
I think the Slido is jammed a bit. A very interesting ECG indeed.
Yeah, correct. So I'm sure everyone has already put up the answers, or we can't see the results.
Okay, just started.
Okay.
It's quite similar to your patient, Choi. This one.
Yeah, it's very similar.
Sorry, doctor. Some technical glitches. Let me try to do it again.
But answer, we got the answer already, no? A lot of people already start answering, and in fact, they most got it correct.
So the answer is the first answer. Go.
Yep.
Yeah.
Acute anterior STEMI.
Yeah, you know, back in school and uni, we were told when you don't know the answer, choose the one with the longest answer. So I guess so that's what most people chose. But also, it's very similar to what Choi had shared earlier. As you can see, if you can go back to the ECG, the ST elevations are in the anterior and the lateral leads. Anson, can we have the ECG, please?
Okay, sure.
Yeah. Back one slide, please. Seeing the ECGs, yeah. So you can see the ST elevation is in 1 AVL, right? V2 all the way up to about V5, V6 even slightly, right? I mean, I think it's more of, V2 to V4 and lateral leads. And like what Choi had mentioned earlier, since the anterior and the lateral walls are affected, you see the reciprocal changes in the inferior leads. So you can actually see the ST depression there in 2-3 AVF. So congrats for all those who got the answer correct.
While we are here, Naveen,
yeah.
Can we entertain one question from Dr. Yu? He was asking, for upslope ST elevation, where would you be measuring the point be? From the start of the upsloping or at the upper end?
I mean, you have the laser pointer. Maybe you can just show the J point, will be.
Yep. I'll show this one.
Yeah, so that's what we call the J point, and it's actually from that point onwards. So you can see in this ECG is definitely 2 boxes above the J point. Right, so it's just the beginning part of the upsloping segment. And it's from
add to that. If you look at the tombstone, it's supposed to be the tombstone appearance. It will be the left corner, of the tombstone. So the left upper corner.
Yeah.
Yeah.
So that's the isoelectric
just the
line,
corner.
and it's 2 boxes above that.
Yeah, that would be the J point.
Yeah.
Okay.
All right. So we the angio, if you can, we haven't shown the angio yet. So like how everyone had correctly predicted, it's actually lesion in the proximal LAD, right? You can just see a stump there where the arrow is pointing, and post PTCA you can see the flow is established. So again, why you have the lateral aspect involvement is probably because the diagonal. There's also, can you actually just point to that diagonal? That the diagonal was also occluded because the lesion was very proximal.
This one?
Yeah. No. Yes. Lower down the diagonal. Just that's
See
the
the
septal
septal, this is
opposite.
the diagonal.
Yeah. Correct. So as you can see,
Count
the
one.
right, since the lesion was proximal LAD, you didn't have flow down the lateral aspect of the heart. So that's why the ECG showed ST elevations in those segments. All right.
Okay.
So we'll go to the next question. Okay. So here we have a 56-year-old man, ex-smoker. This was a stable patient seen in clinic for intermittent chest tightness with activities. What troubled him most was actually the pain happened during sexual intercourse for the past 6 months and associated with feeling breathless. Troponin in clinic setting was mildly elevated. The upper limit of normal is 14 and his was about 15. Also, we have the benefit of an echo here. We will not dwell much on the echo. Probably we can go to the ECG. Okay, so ladies and gentlemen, what is the diagnosis? Acute anterior ST elevation MI, acute inferior ST elevation MI, widespread ST depression, consistent with myocardial ischemia, or non-ST elevation MI. A bit tricky question, so we will discuss it after the polling.
Anson, polling.
Hold on.
Yeah, so the chop T actually is quite low. I mean,
Yeah,
Show
yeah.
the candle.
It's mildly elevated, you know, but not the kind that we see with acute coronary events.
what is the troponin T level that you deem significant, Navin?
Usually, if you look at the guidelines, it's more than 99th centile of the upper limit of normal.
So this is, you think is significant?
Well, it's mildly elevated, but it may not be significant enough to warrant acute intervention, like in a case of non-STEMI or MI. Can we get the answers? Is the polling happening?
You remove the share.
Okay, I think we will not doing polling now since there's a technical glitch with the Slido. So whoever answered previously will probably get the point lah. After this, no point. Let's go.
Well, I wouldn't say it's the correct answer, but the best answer here would be C. Widespread ST depressions consistent with myocardial ischemia. Why I say that? Because it's non-territorial. If you go back to the ECG, you can actually see that the ECGs, there's ST depressions in the anterior leads, in the lateral leads, and even in the inferior leads. So if you were thinking of reciprocal changes, then try looking for ST elevation, but you don't see that in any of the leads. So then you can say it's more of a widespread ST depression consistent with myocardial ischemia. And why I said this is the best answer, because even if you answer D, you're not entirely wrong, because non-ST elevation MI or non-STEMI is defined as ST depressions or T inversion with mildly elevated, elevated troponin T or cardiac enzyme. So as Ko had pointed out earlier, his troponin is mildly elevated. But the best answer here would be C. And if you actually go to the angiogram images, yeah, you can see that this patient actually has triple vessel disease. So you can see the first picture is actually the circumflex, right? There is a tight stenosis there, even involving the obtuse marginal. And also the LAD, tight lesion, right? Even at the ostium. You can see the circle on top, the ostium of the LAD. And the right coronary artery is also occluded, totally occluded from the mid segment. So this gentleman actually has triple vessel disease, and the ECG shows widespread ST depression consistent with myocardial ischemia. So this is the kind of patient that we would refer, he's stable, refer to the surgeon for early bypass.
Right. So it does localizes, but it localizes to all the three arteries.
All the segments, yeah.
Okay, Shamros, your case
Yeah.
next.
Okay, I'll be very quick. We don't have much time left. 54-year-old gentleman, dyslipidemia, impaired fasting glucose, strong family history of heart disease, presented to ER, tight left-sided chest pain more than 12 hours from the onset. Went to see GP earlier that day, given antacids, no better, and then came to ER. Troponin mildly elevated, 195. Can we just show the ECG, please? Okay, so this is the ECG. Remember our teaching earlier, focus. ST elevation, if you can't see ST elevation, ST depression. If you can't see ST depression, look for any T inversion. It may be subtle, okay, but it's there.
Polling, please. Anson? Remain the slide, Anson, so that people can see the ECG. Okay. I think most of them got it correct, no? C.
Yeah, very good. So obviously, Choi, they've been listening to what you've been telling them. So yeah, I mean, very subtle, but it's there. Let's show the angiogram. Okay, so basically he had multiple areas of stenosis. The first one, distal circumflex, and then he also has in the second picture high OM kind of disease. He also has a distal, very small RCA kind of disease. So this patient, we actually didn't do any stenting or ballooning. We just continued on medical therapy for distal and branches disease. He's been very well for the last 3 years. No further issues. Next. 33-year-old gentleman, smoker, no other known significant past medical history. He had 24 hours of intermittent chest pain, saw GP twice, told possibly GERD, but he wasn't very happy, came to ER subsequently. Troponin was elevated at almost 1400. Echo should preserve LVEF. Can we just show the ECG, please?
Anson, polling. The option D, SR, means that it is sinus rhythm, right, Shamros?
Yes, yes.
Okay, Anson, remain the slide so that we can see the ECG.
Yeah, can you show the ECG? I mean, again, as I said, ST elevation, if you can't see, look for ST depression. If you can't see, look for any T inversion.
Okay, so I think the polling closed. So, Shamros?
Okay, what did they say? What was the answer picked?
Nobody answered anything. I think technical glitch, but anyway, we proceed.
I mean, the answer, if you can look at the ECG, there are actually T inversion in the lateral leads. Let's just show, so answer D, yeah?
Yeah.
Can we
See
just
my
show
arrow there?
Yeah, can we just point it, one ABL and V6 there. Okay, can we just show the angio? So this guy was actually quite young, 33-year-old. He has a very small high OM occlusion, but the other major arteries didn't show any significant diseases. So we actually didn't do anything for him, continue on medical therapy. It's been 4 years since. It's very well with no stents, but on strict medications and, risk factors management. Next.
Okay, this is the last one. I think we're going to let everybody see the ECG. I mean the history first, Shamros.
Okay, 54-year-old gentleman, sudden onset of chest tightness, sweating, breathless, 1 hour after playing football, came to ER for further assessment. Troponin was almost 1000. Echo again, a preserved LV systolic function. Can we show the ECG, please?
Okay, so let's go.
Okay, again, focus on what we've been discussing, any ST elevation or depression, T inversion, taking in context with the symptoms of presentation.
Is there a polling, Anson? Remain on the slide for us, the ECG slide.
May not be so obvious, but it's there.
This is very tough one, Shamrus.
Yeah, very subtle. Probably, it's okay. I mean, it's a tense question, so hopefully they will get it. Well, okay.
Divided answer. Some say B, some say D. So between anterior MI and also minimal lateral SC depression.
I mean, the right answer was D, okay? So can we just show the angiogram, please? So again, this patient has a triple vessel coronary artery disease. Okay, the first picture, top left, circumflex disease, OM disease, and then the LAD also severely diseased, RCA, and then the last picture, the circle should be at the bottom, at the distal RCA territory. So he had multiple, areas of stenosis, was referred for bypass for further opinion. Okay, I mean, that's it from me. I mean, some of these ECG may not be so obvious, and we can see sometimes it's very hard from the history to know whether these are artery related or GERD related, but sometimes if it's recurrent, throughout all our grand rounds, the point has always been if patients keep presenting with similar kind of presentation and whatever medications we have tried didn't really work, maybe we should start thinking maybe there's something else going on here. And refer at least for opinion, if not more.
All right, very good. So, Anson, are you looking at the winners, the polling? While you're looking at that, maybe we can look at any Q&A here. Oh, no Q&A. We have answered most of the Q&A earlier on already. So let's look at the winner. The number one winner is Dr. Lee Wan Tin. Is it our Dr. Lee Wan Tin? Congratulations, Dr. Sunita, Matt, JR. How do we get prizes for Dr. JR? Because I don't know the real name. And Dr. Pang. Anyway, congratulations. So I think all the ECG shown hopefully will stick to your mind. I got a question for Dr. Shamrose. You show a lot of patients that come in like a reflux symptom, chest discomfort, and then was prescribed what do you call that? The gastric medication. What is your advice to the primary care physician the next time when they see patients that really come in with a gastric pain?
I mean, most of the times these patients do have acid reflux. I mean, generally you have to, history is very important. I mean, like Dr. Kanan always say during our grand rounds, always comes back to history. And number two, risk factors and the likelihood of them having coronary artery disease. I mean, like the young patient, 33 years old, he was a smoker. So, everybody would probably think it was reflux to begin with. But the fact that it was persistent, with no relief whatsoever with the antacids, that's why he actually in the end came to the ER for further assessment. But it's very difficult sometimes. But the likelihood ratio, the story, at the very least do an ECG. Sometimes the first ECG may be normal, so you have to repeat the ECG, 10, 15 minutes later in the acute settings. But in the chronic kind of stable angina kind of setting, even the ECG, the first few may be normal. So not so easy. But of course, here we have the benefits of echo, serial ECG, blood test. For the GPs out there, sometimes it might not be so easy to pick up these kind of subtle changes. But if you're not sure, just refer, get an opinion. There's no harm.
Right, great. So I guess from all the 10 cases shown, what is the most consistent was actually the symptoms. So all of these patients came to see us with symptoms. Then we assess the patient, we check the risk factor, physical examination, and then the ECG is complementary. We will add on to our diagnosis because the suspicion is very important. Because when we suspect, then we look at all the leads, see which leads, and then of course, when we train our eyes to look at all these subtle ECG changes, and then we will start the treatment immediately, even in a clinic setting, aspirin, and if you have Plavix and you're confident enough, then you just load Plavix. If you're not too sure, always you can contact any one of us here, WhatsApp us, call us. We are all very friendly cardiologists here, and then we can advise you. Now it's very easy. Not like last time you have to dial the phone and no WhatsApp. Now you can just WhatsApp us the ECG. And I hope you all learn a lot from this. Any final remarks from the panelists? Troy?
Yeah, I think it's been a very fruitful session. Most of the ECGs are quite classic. I hope.
And Shamrus?
No, I mean, thanks for joining us. So hopefully you pick up. I mean, the few important things: ST elevation, ST depression, T inversion. Always look out for these things, and then repeat ECG.
Yeah. Well, I mean, again, I think history is very important. Don't take patient symptoms lightly. Even if they keep coming to you for the same complaint, you probably will need a more in-depth assessment, right?
Yep.
Yeah, I think the series of ECGs, the first ones were quite obvious. Some of the rest were not that obvious. So it was a good session. Thank you, everyone.
Oh, one more thing before I end. Actually, very important point is time is myocardium. You can see that most of our patients, if they arrive early, we take in for a CAT lab for primary percutaneous coronary intervention, which is the primary PCI. Actually, the result is very, very good, and you actually can save the patient life. So don't delay. Ask the patient if you are not too sure, refer early. When we see early, we access, we bring in for primary PCI. The outcome actually is excellent. All right. So thank you very much, all the audience, for joining us this wonderful Saturday afternoon, and we will see you again in the next round of SJMC Cardiology Grand Round. Bye bye.
See you.
Bye.
Bye.
Thank you, doctors. Thank you, everyone, for taking time for this wonderful afternoon. I will share the QR code for the CPD points. Kindly use your MLA app to scan it for points. The CPD QR code will expire within an hour. Today's video will be available in both VOPBS, YouTube, and Facebook channels, which you can revisit or share with other doctors. We will stop the broadcasting shortly. Thank you, Dr. Paul, Dr. Choi, Dr. Yap, Dr. Navin, Dr. Shamrus, and all doctors for being available for this session. Thanks again and have a pleasant week.
Thank you.
Thank you. Bye-bye.
Thank you, everyone.
Thank you.